Good afternoon and welcome to a critical exploration of disaster recovery and business continuity best practices, a complimentary webinar from HealthSystemCIO.com sponsored by Optimum Healthcare IT. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com and I'll be your moderator today. We encourage you to ask questions. Go ahead and send them in as they occur to you. Type them in the Q&A box in the lower right-hand corner of the screen and leave the default set to all panelists. I'll be looking at those and getting them ready for our Q&A later in the program, but go ahead and send them in as they occur to you. You can download the deck at any time. You have the URL in front of you. There's a shortened URL at the bottom of all slides, and I'll send it out in the chat box as well. And we are recording today's event, and we will post it on our YouTube channel. Definitely within 2 business days and usually sooner. You'll get an email as soon as it's ready for viewing. So this is how we're going to spend our time today. We're going to go about 45 minutes. First, we're going to hear from Chuck Podesta, CIO at UC Irvine Health. And then we're going to hear from our sponsor, represented by Brian Barnett, Principal Consultant with Optimum Healthcare IT. Then we'll have our Q&A. So without further delay, I'm going to turn it over to our good friend and frequent speaker, Chuck Podesta. Chuck, thanks for joining us.
Thank you, Anthony. I appreciate it, and thanks everyone for taking time out of your busy schedule to participate with me, and hopefully you'll get some information here that you can use and really help you in kind of putting together a disaster recovery and business continuity program. So, when I first was talking to Anthony about this. I was thinking about, I do run marathons, as a lot of you know, and during the training of a marathon, there is training runs and then the marathon itself, and I started thinking about things that could happen along these types of runs, and a lot of them are avoidable, some are unavoidable, and you really have to plan in a marathon. Because once you get out there and you get out to mile 1, mile 2, if you forgot something or you didn't do something right with your wardrobe or your shoes or something along those lines, your socks, I mean, you're stuck at that point. So it's a process of trying different things as you train, and then as you do run the marathon, hopefully everything comes together and you have a good run. But some of the things that are avoidable that you can see in a marathon, hitting the wall. There's training really gets you to the point where that doesn't happen. So you need to train well. Gut distress. You got to be careful. You got to understand your body and what you can eat when you're running and what you can't eat. Heat stroke certainly, depending on the weather, and hypothermia. Also depending on the weather, overhydration. You really have to understand your body and how much liquid that you need. And something called bonking, which is actually when you don't get enough sugar to the brain, basically, or enough blood to the brain. You will start to hallucinate. And I actually had a run where an individual was right next to me about 24-mile mark, and he looked over and said, "Hey, man, can you do me a favor?" And I said, "Yeah." And I looked over and he goes, "Can you tell me if my teeth are in my mouth?" And I said, "Yeah." And he said, "Oh, good, because I thought I lost them a while back." So, but he was running, his legs were moving, and he seemed fine, but he was definitely bonking. So we got him over to some help pretty quick. On the unavoidable side, there's things like the weather. You can't, this happened to be the Boston Marathon, which I ran. You can see the weather. It was really bad. It was cold, but that's not too bad. I mean, the temperature, but it was really windy and rainy in your face and that sort of thing. So you have to plan for that as well. You know what the weather's going to be, so you have to, plan your wardrobe. Crashing and falling, I mean, again, that's unavoidable. All these things have happened to me. I actually crashed into somebody. I didn't actually fall, but there's a spectator running across. Blisters have those. A shoe come off. I've had that on a training run. Not fun. And a wardrobe malfunction, I'll leave that to your imagination on that. But all these things have happened, so you need to put, I needed to put a plan in place to resolve these in case they happen again. So again, just like a disaster in your data center or with your applications, that sort of thing, you need to understand what could possibly happen and then put plans in place to avoid those. So that's kind of a little bit of an analogy of the marathon running. But let's get into the actual project itself. I've been here for almost a year now, and last November, we actually kicked off a project of disaster recovery and business continuity. We definitely have data center issues here, and I thought it was really important that we understand, what those are, but also what we need to do from a DR perspective and from a business continuity perspective to really limit our risk. And so these were our objectives, as you can see, to really, develop that business continuity, high availability, and disaster recovery standards. We wanted to engage the organizational leadership, make sure this wasn't an IS project, which typically they look at it as, but it really requires, especially in business continuity, the entire organization to be involved. And then, again, the timelines, resource requirements, budget, because this does cost money to get this stuff done, but it's really important to do. A little bit about terms, because it's really important. This is something, once this webinar gets posted, you can, download and print it. But these terms are really important. You need to really understand what disaster recovery is, and that's a plan basically that you need to recover from an unforeseen incident or even a foreseen incident in some cases. But a disaster could be natural or man-made for sure. High availability is really setting your systems up so that they're replicating themselves, so that if you do have a disaster, that you have 100% operational response, it never fails. Again, that's very costly, as you'll see in the next couple of slides, but something that you need to consider. Business continuity, on the other hand, is really on the business side. It's really what your customers or your users need to be doing, because it's not if, it's when, that you're going to have a disaster. So it's really important that the business community and the clinical side of your organization really understands that when you do have a downtime, what are the procedures that need to put in place. So that's where business continuity comes in. Business or impact analysis, or BIA, that's really part of the whole project. It's actually really the first step of the project and really identifying the effects of each of your applications. How critical are they? Certainly in an electronic health record, you want that up 100% of the time, but there may be some other applications that if it went down on a weekend or something like that, it wouldn't be as important to get everybody involved in a disaster recovery process at that point. Recovery point objective is important to understand, because that's a point in time that you're recovering the data from. Again, if you're doing daily backups, you might only be able to recover. Your recovery point objective could be 6 or 8 or 12 hours, as opposed to if you had high availability, which your recovery point objective would be basically 0 at that point. And your recovery time objective, which is, how long does it take to recover and get the business back up and running. And again, depending on how you set up your disaster recovery plan and what your business impact analysis is telling you, that could be hours or days or even weeks, depending on the type of disaster that you end up running into. Also, some other definitions, disaster avoidance. And again, this is an effort. It's mostly an IT effort, and it's really looking at your organization. That's kind of what we did here. We know we had weaknesses in our data center, so we looked very closely at all the things that we could do, replication of data, things like that, in a real-time fashion, to avoid a disaster, so that if there was a problem, systems would cut over to backup systems and things like that. So that's something that definitely needs to be part of your disaster recovery plan. And it does cost money, so you need to really map that out. In a disaster recovery during a disaster, that is mostly an IT effort as well. Everybody's relying on you to get everything back up and running and communicate and all the things associated with that. On the business continuity side during a disaster, so during a disaster, business continuity is definitely going to kick in. Again, that's mostly the business side of things, and that's running their downtime procedures, communicating. That's particularly critical in an electronic health record. If that goes down, the business continuity plans need to be really well tested and everybody understanding what those are. And then business recovery post-disaster, there's always that component. For those of you who've been involved in disasters, on the business recovery side, there's always data that needs to be entered, depending on the recovery point, the RPO. If that's not from the moment, that's never going to be from the moment from the moment you went down to the moment you come up, there's a period of time there where you were taking care of patients. So you need to have a plan to really, enter that information in so you can keep your electronic health record whole. There's an example there of registering patients after a lengthy downtime. Just a little bit on data center tiers. Important to understand these. We are actually at a tier 1 right now. We're in a process of working with the other UCs in California to. We've got a data center strategy where we're actually going to have a primary and secondary data center that will both be tier 3s. So we're moving in that direction. But right now we're in a tier 1, which you can see is really small business. And UC Irvine Health is not a small business, certainly. So, and we're in the healthcare business. And you can't afford, 30 hours of downtime per year with no redundancy. That's not acceptable, especially with electronic health records. So we'll be moving up the tiers, and you can see how those go. And most data centers, I think, in healthcare are around the tier 3. The cost associated with going from tier 3 to tier 4 is tremendous. And unless you're the stock exchange on Wall Street or something like that, it's the risk versus reward on that is probably not going to cut it. So on our project, this is a project framework that we put together, and if you look at the costs associated with each tier, you can see the business continuity piece. If you just do business continuity, so you have downtime procedures, things like that, that doesn't cost a whole lot. It takes a bit of time with your business community. You've got the downtime procedures in place, backup procedures. You can see on the left side the downtime increases. That's probably because you haven't done anything with high availability or disaster recovery. So you're just trying to keep the business running in a manual mode. That can work with some applications, but certainly not with an electronic health record. So you need to move it up, step it up, get your high availability running. Dual BOW connections, dual network connections, all the things associated with high availability, and then move it into the third tier, which is disaster recovery, which is really, and if you use again an electronic health record, is always on. You want it to be always on and never have any downtime at all. But again, that costs the most, but it's also has the least amount of downtime involved. So it's a nice little pyramid or triangle here that really, to me, really sums it up. So a sample, kind of phase 1, and this, depending on how you go through this, and what companies you use to go through this, they pretty much go through the same process. Phase 1 is really understanding what you have, what your application portfolio is, what your infrastructure looks like, your data centers, really getting an inventory of all that. Also looking at what's coming down the pike. Are you changing electronic health records, upgrading, things like that? And then start to look at those high availability options to support RTOs and RPOs, especially in the case of electronic health records. So as part of phase 1, these are some sample high availability DR options. So you can see basic recovery services. That might be for some applications that certainly aren't critical. And your business impact analysis, which is your next phase, will tell you which applications fall into kind of basic recovery versus advanced versus continuous availability. Certainly on electronic health record, you want to be on the right side of this slide. And when it says recovery time 0 to 24 hours, you probably want to be real close to 0, and recovery point 0 to 5 minutes makes a lot of sense. But you can see the characteristics of all the things that you need. Very expensive as you move from left to right on this particular slide. Then you move into phase 2, which is actually looking at, once you understand your application portfolio, it's looking at the criticality, from the payroll system all the way to the electronic health record, and doing a business impact analysis and really looking at, putting them in a tiered approach, not the same as the data center tiers, but you can see by, doing virtual apps, you can really kind of impact, and that's why you see a lot of people moving to virtualization, is you can really impact your recovery time objective and recovery point objective with not a whole lot of costs compared to some of the other options that you have. So you're gonna start putting those apps in, and hopefully electronic health record you have in that virtual apps. And then you got tier 1, tier 2, tier 3. Tier 3 might be or tier 2 might be a general ledger system or something like that. And if you have a component failure, facility disaster, regional disaster, these things, you've got a plan for each one of those. Regional disaster would be something like an earthquake, where there's probably more important things going on than keeping the systems up and running at that point, but you'd still want to be able to recover from that. So so that's a cool slide that we put together that really then you can take a look at your business impact analysis, conduct your workshop with those application owners and then plug those applications into these tiers, and it'll give you an idea of what it's going to cost, but then also the technology that you're going to need, which is really the phase 3 side. Once you understand the applications that you need to keep up and running and what your RPO and RTO is, then you can design the network infrastructure, the network services, the storage, replication, backup, client services, things like that. Are you going to get into VDI? What your patching program is going to be. Things like that all come into play here. So again, it's understanding your application set and then doing your network design and your infrastructure design, not the other way around. So you can see you need application expertise, but you also need infrastructure expertise as you go through this. Phase 4 is really then once you have that in place, now you can actually develop the DR plan around these applications and the criticality of these applications. So you get into the plan itself where you're identifying roles and responsibilities in the event of a disaster, and you can go down through each one of these, plan activation, notification procedures, emergency response procedures, and on and on and on. And then also a maintenance plan strategy going forward. So, and there's much, much more than this in developing a DR plan, but it kind of gives you an idea of, you're in a disaster and this is the plan that you want to create. And you also want to be able to test this plan as well, along with the next step, which is the business continuity plan. So once you have the disaster plan in place, so your application criticality, what you're going to do in the case of a disaster, because something is going to happen. You have a component failure, or something definitely is going to happen to you at some point where you're going to have some downtime. Now you can get into the business continuity plan, and this is where you bring in your business owners, and you identify those areas, the scope of the plan, the critical functions in those areas. If you look at the electronic health record as the example, business continuity is huge in that area. Depending on how long the system's going to be down, you might have different business continuity plans for something that's 0 to 30 minutes versus something that's going to be 4 hours or longer, especially in an electronic health record. Those plans could be very, very, very different. So you want to be able to create a plan to maintain operations, create that checklist, location of backup supplies, equipment, plan itself, contact information. And it's funny, location of the plan, a lot of people, it sits on shelves, and you do have a disaster and people can't even locate the plan. So if you don't have a way to locate the plan, there's no way you can use the plan. But it's amazing how many organizations have that issue. Again, I said the downtime plan is based on length of downtime. You want to be able to test that plan. That's extremely important. You want to at least do it a couple of times a year. And there's a variety of ways you can do it. You can do a tabletop exercise just within the IT organization, get everybody in a room. You can do a structured walkthrough, with the users or your customers as well, which I would highly recommend on a DR BC plan. And then disaster simulation testing, where you actually call out a disaster, whatever it might be, power outage or something along those lines, and then kick in your disaster plan, kick in your business continuity plan in a kind of a real-time fashion, and really stimulate it. And you can learn a lot from that. And then reviewing the plan annually and adding new things in as you do the testing, because you're going to find things that you didn't think about, and the testing will certainly call that out for you. So really, you get to the critical success factors in my mind in putting this together. And again, the sample phases that you saw are the process that we went through. And I think it's really important that you understand kind of that order of things, because people have a different view of what disaster recovery is and what business continuity is. But I think if you follow that, for a 5-step or 5-phase process, you'll come to, you'll be able to organize the project in such a way, you'll be able to budget for it, create timelines for each of those phases, and then understand when you need your users and customers and when you don't. And I think those 5 phases are a really good roadmap to get you to where you need to be. But the critical success factors, again, it's not an IS project, especially with business continuity. You need everybody on board, especially when you look at an electronic health record. That's probably 90% of your organization is touching that in some way, shape, or form. So that's huge to get them involved in this project, and that you get senior leadership support on this stuff. And again, it does cost money. Outside expertise, I can't tell you how important that is. When I was in Vermont prior to UC Irvine, we tried to do this on our own. Assign somebody in the CTO's area and put them on the project, and again, didn't have the expertise, didn't understand the 5 phases. We just thought we could throw somebody at it. 2 years later, really had nothing to show for it because the person gets pulled on other things. You really need somebody who knows what they're doing and come in and work on it, full time, and get you to where you need to be in 6 months, not in 2 years. So that's extremely important in my mind. Detailed documentation procedures so that the plan activities can be executed quickly. I mean, I can't say enough about that. Whether it's a BC plan or DR plan, when you're testing it, the documentation needs to be very complete, very detailed. And then dedicated resources. Again, this is where the cost comes in. This is not just something that sits on a shelf. Like I said, it's tested, it's updated. So you need dedicated resources, people. It's a full-time job that they just work on this stuff and keep it up to date, always improving the infrastructure. And, again, that changes over time along with applications. You're adding new applications in. So you need a DR component and a BC component. Every time you buy a new application, you've got to kind of run it through that business impact analysis and then come out with, the criticality of that application and plug it into your DR and BC plans. So hopefully this was a high level, but it gives you enough of a roadmap that you can use and bring in some outside expertise, assign somebody in your organization, get moving if you haven't done this yet. So hopefully this was helpful, and I'm going to turn it back to Anthony.
All right. Excellent, Chuck. Great presentation, and look forward to the Q&A. So now it's time to hear from Brian Barnett, Principal Consultant with Optimum Healthcare IT, which has graciously sponsored our event today. Brian?
Thank you, Anthony, and thank you, Chuck, for your insightful presentation, and thanks for the opportunity to share a little bit about Optimum Healthcare IT. I want to continue Chuck's marathon analogy and point out that business continuity and disaster recovery is not a marathon or is a marathon, and it's not a sprint. In a marathon, the best way to run your fastest possible race is to start out at a pace that you can maintain and sustain over the entire race. BC and DR efforts have a tendency to start with some type of big bang or some major event, a major downtime, and that sort of turns into a fire drill or a sprint, if you will, and everybody's running around trying to create some BC and DR processes, and it's tough to maintain that pace. So more long-term success can be found if we have a sustainable pace, both from a personnel perspective as well as a capital perspective. So Optimum Healthcare is pleased to sponsor today's webinar. Hopefully it'll help the attendees find and maintain that sustainable pace. The healthcare IT space certainly has no shortage of consulting firms, but at Optimum Healthcare IT, we think that our core values are what differentiate us in the marketplace. We focus on 3 things, and that's excellence in service, the passion for our work, and then making patient safety a top priority. Attaining these core values starts with listening to you, our clients and prospective clients, learning your needs, your expectations. Then we provide qualified and experienced candidates who become essentially part of your team. And finally, we stay in touch through the course of the engagement to ensure that we have mutual success. If I were in your chair, one of the questions I would ask is, why Optimum HIT? And here are the few of the reasons why we think we should be your consulting partner. I'm not going to read through this slide, but I do want to point out a couple of important points. First is our track record. Our clients are 100% referenceable, and that's due to the strong performance that our consulting team provides. And then secondly is our staff, our people. We have over 300 clinical and technology professionals on our team. Most, like myself, have more than 16 years of relevant healthcare experience. We focus exclusively on healthcare IT, and we have the resources and experience needed in order to support the large and complex healthcare projects and implementations. The services that we can provide are really tailored to meet the specific requirements of your organization and your project. But this slide sort of gives you a broad overview of the services we offer. On the front end, we can provide strategic advisory services, which include things like disaster recovery and business continuity that we're discussing today. We can also provide implementation, training, and go-live support services around all the major EMRs as well as technology platforms. And then after the live event, we can provide services around optimizing the build and the workflow, as well as remote support, be that Tier 1 or Tier 2 support. Our client base and project experience spans the country and the healthcare industry, as you can see on this slide. And again, I'm not going to read all of these names, but from Children's Healthcare of Atlanta and the WellStar system in Georgia to UCSF Medical Center and also UC Irvine Health in California. We have consultants all across the country that are working on a variety of projects and implementations, and we encourage you to consider leveraging our experience and expertise for your organization. As Chuck alluded to earlier, many organizations consider a BC or a DR project to be a quote-unquote IT or a quote-unquote infrastructure project. But we believe that a strong BC and DR posture really only exists at the intersection of having reliable IT infrastructure and applications, along with dedicated resource capacity and mature processes. Very similar to a three-legged stool, if any one of these areas is too weak, then the organization may not have the solid platform that they think they have and that they expect to have in the event of a disaster. Our efforts around BC and DR begin with evaluating your current technology and application footprints, as Chuck mentioned earlier. We start by looking at your infrastructure. What's the current state of your technology footprint? What are your data center capabilities and capacities? And what are your existing disaster recovery standards? When is the last time that was exercised, whether that's a tabletop exercise or a full-blown simulation? We also look at the application inventory. We work with the organization to rationalize and categorize that application inventory into tiers. It can be an ABC or a 1, 2, 3 or a gold, silver, bronze. The organization can pick the tiering nomenclature, but the point is to be able to focus the BC and DR activities. And as Chuck stated earlier as well, really to be successful with this, you need to engage key external stakeholders. This does not need to be just an IT effort. And with their help, we typically prioritize the application inventory. And this pays dividends not only from the BC and DR perspective, but from a support perspective, from a staffing projects perspective, et cetera. Next, we evaluate the maturity of your existing tool sets and your processes around BC and DR. We'll look at your IT service management platform, including its CMDB or configuration management database capabilities. We evaluate your policies and procedures, your documentation standards, and your compliance against those standards. And really the goal of this process is to eliminate the tribal knowledge phenomenon where only certain people have certain pieces of information that would be needed in the event of a disaster. We also evaluate your processes and their maturity, things like change control, standards around project management, and your PMO. And the real goal of this effort is to bake, if you will, the DC and DR framework into the organizational processes. This should not be a disparate or separate effort. Ideally, it's integrated into the other processes of the organization. Lastly, we evaluate your current resourcing and your future resourcing requirements. We look at available capacity. That may be in the form of one or more individuals, or it may be time that is shared between individuals. What are their capabilities? What gaps exist in resourcing BC and DR activities? Obviously, as we look to deepen and broaden and mature your BC and DR footprint, the resourcing requirements will likely increase. And so what are those requirements? What are the formal designations of roles and responsibilities? and cross-training to eliminate single-threaded resources. So by a single-threaded resource, I mean an individual who has all of the knowledge and experience around supporting a particular application or technology. For example, if your organization only has one SAM guy or one interface lady, then what happens if that resource is also affected personally by the disaster that affects your organization? So you need to have strong documentation, backup designations, and cross-training in place in order to mitigate the risk of those single-threaded resources. In closing, our recommendation is not to consider BC or DR as an IT or infrastructure project. Instead, engage your organizational leadership in that effort. Evaluate not only your infrastructure and your applications, but also your resources and your processes to establish and maintain a strong BC-DR posture. Our goal at Optimum Healthcare IT for these BC and DR engagements is not to create the three-ring binder that contains your DR plan that sits on a shelf somewhere collecting dust, if you can even find it, as Chuck mentioned a minute ago, but rather to engage with your organization in establishing a framework and a process that survive our engagement and provide long-term value for your organization. If anyone today would like additional information on Optimum Healthcare IT, the consulting services we provide, specifically around BC and DR, you can contact Heidi Cravens, and Heidi's contact information is there on the screen. So thanks for your participation in today's event, and I'll turn it back over to Anthony and Chuck.
All right, great, Brian. Thanks so much for that good presentation. Lots of good information in there as well. So now we have some time for our Q&A. So as I mentioned, go ahead, type those questions into the Q&A box, then leave the default set to all panelists, and we will take a look. First question, Chuck, let's start out. This is from one of our good friends with a lot of experience. In my career, I've seen so many problems with the implementation of high availability, particularly software, sometimes with setup of the hardware, some with actual failover, some with testing failover. How has your experience been in this regard?
Actually, that's a super question because it is spotty. I think the technology is better today than it has been in the past. I know when I was in Vermont, we actually set up a software and hardware failover, and it actually, in one case, failed to fail over. So I totally agree that in a lot of these cases that it's been a problem. I think people think that by doing this high availability and setting up hardware and software failover that you know, you check the box, you've done it, you're ready to go. Maybe you've got it set up between two data centers, that sort of thing. But my experience is that you've got to test and retest and test that on a regular basis to see, you know, where the bugs are and run as many scenarios against that high availability as you can to see, you know, where some of the issues are going to be. So I totally agree. It is an issue. It's getting better, but I think if you test, that's the key to success with high availability.
All right. Next question. I have found in my experience that the real validation of readiness and capabilities is by doing unannounced testing. It took several years to get to the point where we felt confident doing those. Have you done that?
Yes, I did we did one of those in Vermont. Haven't done it here yet because we're just, you know, we're at the very tail end of our plan and we're just starting to do the testing piece. But no, I totally agree. I think that's, if you look at any other testing strategy that happens with disasters and things like that with organizations, yeah, they do the testing where everybody's notified, but a lot of organizations do that surprise testing where you know, there's a school bus accident or, you know, something along those lines, and they call out the different codes and everybody scrambles and they're not really sure whether it's real or not real. I think that you really need to do the same thing here and pick a particular application and you know, maybe it is electronic health record and run a test that way, because I think that's, you'll really see how people respond and whether your disaster recovery plan is in the shape that it needs to be in, and also you'll learn a lot more about your business continuity plans as well by doing it that way. I think it takes a while to mature to that level. I think you need to do your first testing is going to be announced type testing, and maybe you do that for the first year a couple of times during the year, but then get to the point where, yes, you're going to announce to the organization over the next year, we're actually going to have unannounced testing. in going forward. And I think that's just another maturity step in the plan itself. So, yeah, excellent point.
Okay, great. Next question. How do you handle a corrupted data situation in a hot environment?
Yeah, well, that's in your business recovery side of it. You've got to be, and it depends what that data corruption is. I know I had an issue in Vermont where we basically, we had some downtime, but then when we came up, some of the backups they were corrupted. There were issues. I think there might have been a virus on one or something. It caused some data corruption, and it really blasted a hole in the electronic health record. So we actually had to figure out, what data was missing, where we could potentially get the data. Some of it had to be manually entered from printed data, that sort of thing, a real mess. So corrupted data is really tough. And again, that's why I think you need to test, and you need to test in a real-time way where you're bringing your backups in, or you're cutting over on your high availability and really looking at the data in your test system to make sure that there isn't corruption there on a regular basis. Because I agree, that's a huge, when you look at your RTO, your recovery time objective, that stretches that way out. Yeah, you can get the organization up and running, but talk about patient safety issues. So if you have a patient's record that's only half complete and they happen to be an inpatient or in your ED or something like that, that can be a real problem. So again, testing is huge to catch those types of issues, because once they are on your backups, they propagate themselves over time, and you may not even know that it's there until you actually need to have it. So again, testing is extremely important.
Very good. Brian, I'd like to bring you in here. You mentioned the concept of the single-threaded resource. That's an interesting term, probably a very good one. Tell me, it's a two-part question. So tell me, I guess you see a lot of this. You go into organizations and you're reviewing them, and you find that Jim is the only one who knows how to do this and Sally that. So talk more about that and how CIOs can go about finding if they have this kind of problem. And secondly, if you've got any funny stories that you want to anonymize and relate to us, anything, I can imagine you've run into some very funny things in this area, but go ahead.
Well, I don't know if I have any funny stories. I guess things get funnier as time passes, but it is a big issue in a lot of organizations, and it's not certainly a strategy of the organization to have that happen. It simply happens as resources are stretched thin, as new projects are implemented, new technologies are implemented. I've seen it on both sides of the coin. So it may be that there's an older technology that some application is dependent on, and over time, people tend to, by their nature, want to morph to the new technology. They want to do the new thing. And so you wind up with this one person that has, all the knowledge, all the marbles, if you will, about a particular application or piece of technology, and they inadvertently, not necessarily on purpose, but inadvertently become that single-threaded resource, a risk in the event of a downtime. The opposite can also happen. You can have someone on a project that learns the latest whiz-bang technology or implements the application. Everything in healthcare moves at the speed of light, it seems like, so unless there's some discipline to focus on documentation and procedures, then you may hit your first planned or unplanned downtime of that particular application, and you don't have the knowledge across the organization that you need in order to properly support that. As Chuck said earlier, unfortunately, sometimes with these things, it takes some type of event that sort of brings them to light, and then once they do, you have to have a strategy to address them going forward. The best way to deal with both of those, as I mentioned earlier, is really strong procedures, strong documentation, and designation of roles. And not only designation, but testing, if I can use Chuck's term, of those roles. So if you're going to do some type of planned or unplanned, unannounced DR test, don't always go to your primary resource who can, check all the boxes quickly and understands all the technology, and everyone can pat themselves on the back and walk away and say, great job, our DR plan's solid. Go to the guy who's the designated backup and see how much longer that process takes.
Very good. Chuck, have you, in your travels, have you come across this, I'm sure you have, this single-threaded resource issue, and have you ever run into a situation where someone was obviously very happy to be single-threaded and understood the power and security that came with that, and was difficult to make multiple threads out of that single one?
Yeah, no, absolutely. We actually, in Vermont, we had an issue with Citrix, and we had a person who was our kind of Citrix guru, and he happened to be on, we had an issue with Citrix. He happened to be on vacation, so we ended up with the backup person who was not as skilled, and we learned our lesson on that one. And also the primary person learned his lesson because we ended up having to pulling him, off his vacation basically to, get the system back up and running. So he learned a lesson. He had all the power, and I think he liked that. But then when he came back, he realized that if he's ever going to take a day off and have some fun, that he better get the backup person, as skilled as he was. So that's probably the best example I have of a single threader, but it ended up being a positive ending in the long run.
All right, next question. You talked about things that can come out during testing. Anything you can think of that surprised you in some testing you've done? The failover stuff that we talked about earlier. We had some gear. I mean, we spent a lot of money in Vermont when we went live with Epic, and we thought we were bulletproof. We had the failover stuff between one data center and another. We had hardware. We had software where each system would ping each other, kind of like looking for a heartbeat. If it didn't find the heartbeat, it would automatically cut over. And we thought, there's no way in the world we're going to have any downtime whatsoever with this high availability setup from this vendor. And, sure enough, we had a squirrel hit a transformer down the road or something like that, sent a surge down the line, blew out our UPS system, which hardly ever happens. They should be able to, UPSs take a lot of pounding, and actually hit the high availability in a way where it couldn't cut over. The secondary couldn't take over from the primary because of the surge that went through the system and actually went through the primary and the secondary. We ended up with about an 8-hour downtime on that, and it was probably, I think it was 2 months after we went live with the Epic electronic health record. So you can imagine. The only good thing was the organization was we were pretty much paper before that, so they knew how to go back to paper. But if that happened a year later or 2 years later, on the business continuity side, it would have been really, really problematic. So to me, that was a real lesson in that you can't sit back and let the hardware and software, just because you spent all this money and you think you're bulletproof. You really have to test this stuff and think about squirrels hitting transformers. Unfortunately, that stuff is going to happen, or a car accident, hitting a pole, and it's just it's stuff that's even beyond belief. But that's, again, I can't say enough about the testing side. It's so important. Excellent. Well, that's about all we had time for today. I want to thank our featured speaker, Chuck Podesta. I want to thank Brian Barnett and Optimum Healthcare IT for sponsoring. As I mentioned, you'll receive an email when our archive has been posted to our YouTube channel. I just send out the URL in the chat box, but you'll have the URL in the email you get. For those of you who hold the CHIME CHCIO certification, make sure you let CHIME know you attended our event today. Attending them gets you 1 CEU, and if you've asked us to communicate to CHIME, we will. Sponsorship opportunities, contact Nancy Wilcox. Questions and comments, you can email me. And you can go to our website to see our upcoming schedule, where I am sure eventually you will see Chuck again because he's so great. So again, thank you, Chuck. Thank you, Brian. And everybody have a wonderful day.